Good morning, everyone. Okay, I'm going to give just one more minute to round up everyone. It's like herding cats this morning. Welcome to those of you online joining us virtually. As you can imagine, in our first foray of an in-person event, it truly is like herding cats. So we're going to maybe just wait one more minute as others trickle in, enjoying breakfast. Hopefully you are as well enjoying breakfast at home if you're joining us virtually. We're slowly trickling in. So again, welcome today, this morning, to the 12th annual Karmanos Cancer Institute Annual Cancer Symposium. My name is Dr. Elizabeth Heath. I'm a professor of oncology at the Karmanos Cancer Institute, Wayne State University School of Medicine, and I am responsible for torturing all of you this morning as your MC. And why is that? Because for the 12th year, we really find it so incredibly important for all of us to share the exciting knowledge that's happening in the world of science and kind of explain that in layman's terms. We are really, really fortunate to be at the Cancer Institute. Many of you know that's a National Cancer Institute designated center, which means we do a lot of patient care, we do a lot of research, and we have all of you as our stakeholders in the community. So most of you remember that our last in-person event was in 2019. It was here many, many moons ago, and unfortunately, due to the pandemic, we were virtual last year. So this is our first year back as a hybrid event. So we are joined with our colleagues, not just here in Detroit, but also in Flint and Lansing, and we'll go to them in just a second. But I wanted to make sure that we also recognize we have an online presence, so a true hybrid event. This event is being live streamed on the website, so many of us are still in our pajamas at home enjoying this. But for those of you who have come here, you know that we're very fortunate at Karmanos to also have the Institute dispersed throughout the state of Michigan within the McLaren Hospital system, of which there are 14 in the state of Michigan. So for many of you who are not perhaps in the Detroit proper area, there's great doctors right in your backyard, great science, and just really caring people who want to help you. One of the housekeeping items that I just want to bring up is that here in Detroit, our restrooms are right outside that door, women on the right, men on the left, and our vendors, which is our community partners, are right outside, as well as our lovely sponsors from pharma on the other hallway. So you guys here have a lot of opportunity to talk to folks who are in the pharmaceutical industry, as well as leverage all of your community resources, of which I can also say, if you are here with us and or in Lansing or in Flint, the agenda that you have also details out all of our fabulous faculty. Mostly everyone is a Wayne State University School of Medicine faculty, as well as our staff, as well as all of the community resources that you may need. I want to also make sure that we recognize our sponsors, of which we cannot do this event without. Our platinum sponsors, which is Caris, Pfizer, and AbbVie, as well as our gold sponsor, Seagen, and so many others who are really taking the time this morning to make this event possible. But just like what my t-shirt says, it's Team Karmanos. So at this moment, I'd love to recognize our advocates who have made this event possible. So if they can stand up in this room and we can give them a round of applause, that would be lovely. Stand up, guys. Our advocates are just like all of you. Some of them are family members of patients who've had cancer or they're survivors themselves, volunteering their time and expertise. If you'd like to be an advocate, please come see us. We also want to mention that if possible, please turn off your phone. And although I am not masked up here, if you're not eating or drinking at your table, we would appreciate if you keep your masks on. Because again, being a cancer population, we're a little bit more vulnerable, so I would appreciate that if you could. And there's plenty of masks at the table as well as hand sanitizers. The agenda is jam-packed. I'm sure you've seen some of it there in your book, as well as the screens that's been going. So we want to really educate and share with you some of the science, but hopefully done in a way that you understand. There is an opportunity to ask questions at the tables. There are pens and papers if you want to ask, and then what you do is just raise that paper, and one of our advocates, many of them are wearing the apron that says "Ask Me," and they'll come and get your paper, because we're going to try to funnel all of the questions through our chat box. And those of you online, also right below your live stream video, there is a chat box. So if you've got questions, please ask. Because there's so much information, we'd love for you to ask your question during the lecture, because sometimes we're just going to plumb run out of time. So if we do, and there's a burning question, please email communityed, so communityed@karmanos.org, and we will try to answer your question if we are not able to answer it during this meeting. I just would like to really mention that because our event here in Detroit has been so long-standing, and we have this partnership with McLaren, it's really important to get the word out in our community. So I would like to say hello to our Flint colleagues, if they can pop on the screen and wave and say hello. Yay! Good morning, guys. And if we can then now switch to our Lansing colleagues. Oh, yay! And there they are. So we're going to have a grand old party, not just virtually. So those of you virtually will give a silent cheer. And what we'll do is keep you in mind, but for the Detroit crew here, as well as Flint and Lansing, we really want this to be an educational and spectacular event. Now, my motto in life is, no picture, it didn't happen. So what you guys are going to do is say cheese, because I'm going to take a picture of you. All right, and then Leslie, are you going to take a picture of us? We're going to have you guys look that way, and Leslie's going to take a picture of the room. Thank you so much. So that way you guys end up on next year's reels during the welcome. Okay, that's enough of me plattering on. Thank you so much, everyone. And we're going to start off today with a terrific lecture from Dr. Ashley Richardson. As you can see on the agenda, our experts are from throughout the state. She primarily practices at our Clarkston location. If you have any questions, please make sure again to raise your piece of paper, and we can ask that during the chat. Last final reminder, one of the overarching themes we want to emphasize today is the screening of cancers in general and how they've gone down. We'll learn more about that with Megan Landry from the American Cancer Society, but it is really important to keep that lens in mind so that we can also try to improve our screening efforts. So I will now turn this to Dr. Ashley Richardson, who's joining us today from Flint. Dr. Richardson?
Good morning. Thank you all for joining us both virtually as well as here in person. I know that we're spread out throughout the state, so we appreciate you all coming. I have been charged with the task of talking about breast surgical oncology. So basically, where did we start with breast surgery and where we are now? It's a long talk. It starts from the 1800s until 2022, but we're going to try and put this into 20 minutes and leave some time for questions here. Here are my disclosures. So like I said, starting back, we originally started with an excisional biopsy. An excisional biopsy, a woman would have a mass, we would take a scalpel and excise that area. That dated back to the 1800s. It wasn't until the 1930s that we developed a core needle biopsy, where we were able to put a needle into the breast in order to identify what those cells might have been. At that time, we still just went into the breast and either did an excisional biopsy or took the breast off to try and obtain a diagnosis to understand what was going on with the patient. Then in the early 1900s, we started to understand that breast cancer was actually a systemic disease. Systemic means that the cancer traveled throughout the entire body. That led to additional surgery, and that's when the axillary nodal dissection was created. If you look at the picture there, you can see that breast cancer tends to spread to the lymph nodes in the armpit. And there are 3 different levels of lymph nodes in the armpit. Back in the day, and we're talking hundreds of years ago, we used to go in and take out all of those lymph nodes, and that lasted for a very long time. We continue to do axillary lymph node dissection, and we continue to do that today when we need to. There are 3 different levels, and a level 1 and a level 2 is a standard axillary lymph node dissection, but oftentimes we've had to take out all of the lymph nodes and extending into the level 3. Unfortunately, when we do that procedure, there are substantial comorbidities, so arm swelling, pain, discomfort, chronic scarring. A lot of ladies had significant long-term effects due to this extent of disease and the extent of dissection. What we found over time was a lot of the patients did not actually need to have that full dissection. So multiple clinical trials and studies and patients signing up for trials have led to being able to do less surgery within the armpit or the axilla. In 2022, we now do almost always a sentinel lymph node biopsy. So a sentinel lymph node biopsy is where we take out the first few lymph nodes in the axilla or the armpit to assess if the cancer cells have left the breast. So as you can see at the nipple, we inject oftentimes two different dyes that go through the breast and travel up to the armpit to tell us which lymph nodes to take out. One of the dyes is a blue dye, so I always tell my patients that their breast will be a Smurf blue, like you can see in the picture, and they'll actually pee blue-green for a couple days. That's a critical component to explain to the patients. But then the dye will travel into the armpit, and then on average, we take out 2 to 4 lymph nodes. When we used to take out all of the lymph nodes, 20 or so, that risk of lymphedema was greater than 30%. So that's the chronic arm swelling. That was substantial. And that's a chronic thing that can happen at any point in their lifetime. So even if they're 10 or 12 years out of surgery, they could develop lymphedema that would then be a chronic issue for them. With a sentinel lymph node biopsy, that risk of lymphedema went down to about 5%, which made a huge difference for our patients. So almost always we're able to attempt and do a sentinel lymph node biopsy. In the event that there's additional disease in the armpit or multiple lymph nodes are positive, unfortunately, we still have to go on to an axillary dissection in certain patients. So it's not completely avoidable with all of our patients, but we're able to lessen the extent of surgery and then the extent of comorbidities as well. The modified radical mastectomy began several years ago as well. I think my finger works faster than this button here. There we go. So the Halsted radical mastectomy, if you look at the picture, it was quite graphic. We would take out the skin, the breast, both the pec muscles, there's 2 pectoralis major and minor muscle, and removed all of the axillary lymph nodes. This is how breast cancer really started. We went from the excisional biopsy and moved on to a radical mastectomy. Patients, as you can see, suffered significant pain, scar tissue. I mean, they were really, really, really disfigured from this procedure. And what we learned over the years is we were not actually doing them good. We were over treating them and doing more surgery than was actually helping them. We were creating more problems. They did not live longer by doing this extensive surgery. So then we were able to move on to the modified radical mastectomy. With a modified radical mastectomy, we're able to take less skin, we take the breast off, no muscle is removed, and then an axillary lymph node dissection. There are also times when we don't have to take out all of the lymph nodes, but still perform a mastectomy. Patients now have substantial better quality of life as we are able to reduce the scar tissue and the chronic long-term effect from a radical mastectomy. A simple mastectomy is where we remove the entire breast, keeping the muscle. There's no removal of the lymph nodes unless we need to do that, and oftentimes that's paired with a sentinel lymph node biopsy where we look at a couple of the lymph nodes in the armpit. But you can see that from a scarring perspective and tissue and range of motion, they have significant improvement in quality of life with the exact same overall survival and recurrence risk. Fast forward to the 2000s, and now we are also offering nipple-sparing mastectomy. So as a breast surgical oncologist, I perform a nipple-sparing mastectomy quite often. With a nipple-sparing mastectomy, we're able to make an incision along the inframammary fold, so the underside of the breast. We go up and take out the entire breast, but we keep the skin in the nipple. This is paired oftentimes with a plastic surgeon, and the plastic surgeon comes behind and does the breast reconstruction, oftentimes direct to implant. Also, they use what's called a tissue expander, which is a temporary space holder, to fill up underneath the breast, and then they will go back for a second surgery to have the implant placed. If you look at the patient there and at the diagnosis, she had extensive ductal carcinoma in situ throughout her breast, which warranted a mastectomy. She has a good body habitus and appropriate breast size to be able to perform a nipple-sparing mastectomy. And the picture on the right shows her final results. So she has her skin maintained, her nipple, the breasts are gone, and then there's implant-based reconstruction. Patients were found to have improved cosmesis. It's important to note that their nipple retains no sensation and no function. So it is purely cosmetic. And I express that with the patients oftentimes because they expect to have some sensation afterwards. But in fact, the entire chest wall, including the nipple, is typically numb. Also, from an oncologic or cancer perspective, it is safe to keep the nipple. There are certain times that we cannot keep the nipple. So if the cancer is invading into the nipple itself, where you can see the cancer coming out, if the tumor is just deep to the nipple, then we know that it's probably not going to be safe to keep it because obviously you want to get negative margins. Oftentimes, a breast MRI is utilized. A breast MRI does a good job of being able to locate where the tumor is in relation to the nipple. And there are other factors as far as body habitus. Are they a smoker? Other medical comorbidities that may stop them from being a nipple sparing candidate. But this is certainly something on the front lines when we talk about breast cancer care and breast surgery. It's often offered frequently. And like I said, we pair with our plastic surgery colleagues, usually done at the same time. Here you can see implant-based reconstruction options where a mastectomy can be 2 stages, where you go in for the tissue expander, which is just a placeholder that can be filled with air or fluid, and they would go back at a later date for implant-based reconstruction. There's also a lot of discussion about subpectoral or prepectoral, and that basically means under the muscle or over the muscle. Several years ago, it always used to go under the muscle due to the concern for a recurrence risk and being able to feel the malignancy. We now have a lot of advanced technology, including the breast MRI, that gives us a better idea of the tumor in relation to the muscle, which allows us to have more plastic surgery options. So, from an oncologic perspective, as well as from a cosmetic perspective, ladies have a lot more options in regards to surgical intervention. On the right-hand side, you can see what we call a SPY. This is utilized by our plastic surgeon colleagues to look at the blood flow right at the time of surgery. So that helps us know after a nipple sparing mastectomy or even a skin sparing mastectomy where we keep all of the skin, what's the blood flow and how will they do with reconstruction. We then started doing breast conservation. It started with a quadrantectomy where we would take out, quote unquote, a quadrant of the breast, now more formally known as a lumpectomy or partial mastectomy. This is where basically, even if they don't have a lump, we take the lump out. So whether it's precancer cells or an actual malignancy, we're able to go in and just go around that tumor with a clean rim of normal margins, and that's called a lumpectomy. So you can see in the picture, this patient has a small mass in the upper outer quadrant. We put a clip in that when we do the excision, or I'm sorry, when we do the core biopsy, and then we're able to localize that tumor with multiple different modalities and then go in and take that area out. We also have significantly advanced our ability to do aesthetic scar placement. So, as a breast oncologist, I'm very concerned about where I put my incisions. And although I can't do scarless surgery, we try to hide them as much as possible. So, whether along the nipple areolar complex, along the inframammary fold, we're very cognizant of where we put the scars. We also do a lot of oncoplastic reconstruction. So at the time of lumpectomy, if you notice on the patient, the cancer is right there in the center of that triangle along the lower part of the breast. So we're not going to just go in, make an incision, take it out, and close up and call it a day. We're very mindful of putting the tissue back together, and we'll borrow and rearrange the tissue inside the breast so that her final cosmesis is maintaining the contour and the shape of her breast. Not only are we worried about negative margins, but we also want it to look nice afterwards, knowing that she's likely going to go on to additional treatment with radiation and being mindful of how that scar will look. Patients have been offered many more options over the years when it comes to oncoplastic reconstruction. This is a patient that oftentimes can become a candidate for lumpectomy in conjunction with a breast reduction. So if you have a patient that has a very large breast, we can take out the tumor and do a lumpectomy, and we pair with plastic surgery for them to do a reduction at the same time. And I always stress to patients that that is covered by insurance. It's not considered cosmetic. And so that's a nice option to offer ladies that we weren't able to do in the past. There's a lot of data now to support doing breast conservation. The initial thought was we needed to do mastectomy, and mastectomy was the only option in order to have the same overall survival and the same recurrence risk. However, We now know that with breast conservation, doing a lumpectomy, sentinel lymph node biopsy, followed by adjuvant radiation, there is actually equivalent, if not a little bit superior survival in those folks than mastectomy. So this is often a topic of discussion with patients that come in and are immediately wanting a mastectomy. I take a lot of time in consult to discuss with them that lumpectomy can often be better than mastectomy. We also have a lot of different options in regarding to systemic therapy in regards to chemotherapy, and I know some of our colleagues will talk about that later in the day. But specifically with breast cancer has come a long way in regards to chemotherapy options, and that includes chemotherapy before surgery. So neoadjuvant means doing chemotherapy before surgery. We used to do surgery, have to obtain a tissue diagnosis, and then decide who is a candidate for chemotherapy and or radiation. Now, with all of our advanced technology, needle biopsies, MRIs, there are lots of patients that we now know benefit from chemotherapy first. So they'll undergo chemotherapy, present back to the office for the surgical discussion, have surgery, and then maybe proceed to radiation if indicated. So here you can see that a patient presented with a very large mass in her left breast, had chemotherapy, and following chemotherapy, the mass was completely gone. That allows me as the breast surgeon to do less surgery on her. So in the first picture, she certainly would have needed mastectomy as an entire quadrant of her breast is involved. But afterwards, she does become now a breast conservation candidate and could have a lumpectomy and sentinel lymph node biopsy if she elected to do so. So it allows us to have a lot more options for the patients in regards to surgery. One of the other things that I wanted to just briefly touch on is a high-risk breast cancer clinic. So in my office, we see a lot of patients that are high risk, that have a strong family history, may have had abnormal breast imaging and warranting a biopsy. And that's kind of the importance of a high-risk clinic. The breast surgical oncologists do a very good job of offering genetic testing to patients that are recommended for genetic testing based off of their family history, an abnormal biopsy. We also refer to our colleagues in medical and radiation oncology for adjuvant treatment options for patients that may be high risk. And obviously, we collaborate with plastic surgery as well. In regards to genetic testing, we have also evolved over the years in who we offer genetic testing to and what genetic mutations we test for. Prior to 2014, the most commonly tested was BRCA1 and 2. That's kind of on the radar with most of the general public. However, we now test for over 50 to 70 different genes that relate to multiple different cancers: colon cancer, breast cancer, pancreatic cancer, and all of those can be red flags in a family history, which then prompt me to offer genetic testing to patients when I see them in the office. So there's 8 most common genetic mutations related to breast cancer: BRCA1 and 2, the TP53, PTEN, and PELB2. When a patient's positive for these mutations, I sit down in consultation with them and discuss what does that mean and what are the recommendations. Oftentimes, patients immediately go to mastectomy. Now that is offered and it is covered by insurance with these patients with a genetic mutation, including your moderate risk mutations, CHEK2, ATM, etc. So we often do talk about prophylactic mastectomy, which again is covered by insurance, including the breast reconstruction, which a lot of patients do not know about. But they can also proceed with close observation. And that's why under the NCCN guidelines, it's often states discuss or consider, because it's not a direct indication to do surgery, but setting them up with the breast surgeon is certainly the first step. When we talk about risk reducing mastectomy, that is where when a patient does have a genetic mutation or a high risk marker, and that's prophylactic surgery where we go forward with mastectomy before a cancer develops. The benefits of a risk reduction mastectomy: 90% breast cancer reduction. And that's important to stress to the patient. Even after mastectomy, whether you have cancer or not, there is still a risk of breast cancer. The risk is never zero. They can avoid chemotherapy because you're taking off the breast before cancer develops. They have a less cancer worry, higher satisfaction, and avoidance of imaging. When we talk about imaging, especially in a patient that has genetic testing, oftentimes they're offered annual screening imaging, which consists of a mammogram and a breast MRI, alternating every 6 months. So mammogram January, MRI June, mammogram January, MRI June. And that can be very anxiety provoking in patients. Every 6 months, they're just waiting for a negative abnormal test that would prompt additional biopsies. So I see a lot of patients that they may do that for 3 or 4 years and then present back to the office to say, okay, I'm ready to do mastectomy. However, no surgery is without risk. So it's important to discuss that with the patients that there can be surgical complications, costs involved. Any surgery can create pain or chronic pain. They often have to be prepared about their body image because this is mastectomy. This is not elective breast reconstruction or elective plastic surgery. This is mastectomy. So I spend a lot of time talking about that. Patients are very emotionally connected to their breast. And so there's certainly an emotional component that we have to discuss with the patients. And oftentimes, too, patients present wanting mastectomy when it's not indicated or unnecessary. So just having a family history in and of itself does not put you in the category for risk reduction mastectomy. So oftentimes it's a lot of counseling to patients about appropriate actions, but not including surgery. So as Dr. Heath had mentioned, screening is certainly down post-COVID, and we definitely see that with mammograms. I know October is Breast Cancer Awareness Month, so I'll encourage you to get a mammogram. But outside of October, I would encourage you to get a mammogram at your normal time annually every year because although it's after COVID, we really, really stress the fact of mammograms and screening, and we know that it'll save lives. So thank you for joining me. If you have any questions, certainly happy to field those.
All right, let's give her a hand. Wow. You know, when I hear Dr. Richardson talk, I think what's clear is she knows what she's doing. So, one of the things about screening that comes up a lot is you're just afraid that if you find something, what are you going to do? When you hear Dr. Richardson, and she's a very competent surgeon, one, she's saying teams. So, again, we work in a team setting. But number two, that she's going to go over these options. So, part of the scariness, I think, of any cancer, but especially for breast cancer, is what it means for a woman. What does that mean for relationships? These are kinds of discussions we really encourage all of you to have, you know, with the provider. Dr. Richardson, can you maybe talk about what about when women should start screening with mammograms?
Sure. So the recommendations are to start annual screening mammograms at age 40 or 5 years younger than the first degree relative with breast cancer. So if a patient has a first degree relative, mom had breast cancer at age 42, they're going to be recommended 5 years younger. Now, if they're found to have a genetic mutation, those regular screening guidelines go out the window when we discuss high risk screening. But for the annual routine mammogram, it's started at age 40 and it is annually. I know there's been a lot of information out in the media or just kind of disconnect on how often, but it should be done annually. The point of a mammogram as well to stress is to look for newer changing things. So if something changes from last year, they're able to see that that's a change and that's going to be recommended for additional imaging. If you go several years before, it's very difficult to know is that something that's new or changing because it had been such a lapse in time.
That's fantastic. We do have a question in the chat, which is, as a survivor, I have had calcifications. What does this mean? Does this signal a return of my cancer? Can you address that, Dr. Richardson?
Certainly. So, in full disclosure, I'm not a radiologist, but we see patients with calcifications all the time. Calcifications can be part of the normal aging breast. Your milk ducts can calcify, the vessels, the vasculature in the breast can calcify. It's the radiologist's job to look at those calcifications and determine which look abnormal versus which look as part of the normal aging breast. Oftentimes, I describe it to patients that if the calcifications are round, smooth, like a cotton ball, that if you squeeze them between your finger, they're not going to hurt you. Usually, those are deemed benign. If the calcifications look more irregular and like a shard of glass, that if you squeeze them between your finger, they're going to hurt you, those are the ones that are usually going to be prompted for a biopsy. Post-surgical, you can also develop calcifications in what we call fat necrosis. That's basically scar tissue or just the fat that died from surgery. So could it be a signal of recurrence? It could, or could it be scar tissue or just normal calcifications? Absolutely. That's where your breast oncologist, your radiologist all work together to make sure you stay up on your imaging. And oftentimes they'll recommend a 6-month follow-up mammogram or diagnostic imaging to ensure those calcifications are not a sign of cancer recurrence.
That's a great answer. I think our minds always jump to the absolute worst, doesn't it? So you see something that isn't right, you just almost don't want to know. Another question has come in, which is, can you provide some additional information about HER2? So that comes up a lot, I think, in breast cancer, whether you're ER, which is estrogen receptor, PR, which is progesterone receptor, and HER2. Dr. Richardson?
Certainly. So I tell all patients that there are multiple different forms of breast cancer, and it is certainly not apples to apples. So we go through the receptors or the biomarkers, and as you mentioned, there's an estrogen receptor, a progesterone receptor, and a HER2 protein. Oftentimes, patients will say, I'm HR positive, and that gets very confusing because they're referencing being hormone positive, which is the estrogen and progesterone. And then the HER2 is a separate protein that's on cancer cells. There's a lot of information, especially commercials and new data out there for new medications directed at HER2 therapy. And when you don't have a background in medicine, you can get them very confused because I'll have patients say, well, my mom was HR positive, but now I'm HER2 positive. So I spend a lot of time detailing the differences and what that means for them. So when you're estrogen receptor positive, basically in layman's terms, your body, the tumor is using your own body cell to grow. The hormones in your body, like estrogen, is like miracle grow feeding the tumor. The HER2 is completely separate, and that's a protein that's on the cancer cells that we now have targeted therapy to attack that protein to kill the HER2 positive cancer cells.
That's terrific. Thank you for that. I think we're also in the world of markers and who's going to point to what, having worse disease or better disease. The science is exploding around us. I know some of our sponsors and pharma folks out there, there's a lot of diagnostic testing. So you learn about it. Half of this game today isn't what is your provider going to tell you, is what are you going to do to advocate for yourself or your loved ones? And that kind of information is gold. So what you learn today, you share, because a lot of people don't know this stuff. Now, another question came in, which is, well, what if I do have a positive mammogram? Who do I consult with next? Who do I talk to? Do I look on Dr. Google? Who am I going to trust in terms of a next step? What do you think, Dr. Richardson?
Well, I would say my office is here in Flint and Clarkston. But in reality, when you have a positive mammogram, that radiologist or the result's going to go back to the provider that ordered the imaging. So whether it's your primary care doctor, your gynecologist, it's going to go back to them with a positive result. And then the next step is either going to be additional imaging with mammogram and ultrasound or go directly to a biopsy. Oftentimes that's done by the provider that ordered that initial mammogram. I often see providers will then refer the patient to my office. So if they just have an abnormal mammogram, they'll get them started in my office, and then I'll take the process from there to order the appropriate follow up imaging and possible biopsy. Just because your initial mammogram is abnormal does not mean you have cancer. And this is the other thing that I stress to patients. There's all kinds of reasons why your mammogram may be abnormal. Have you lost weight? Have you gained weight? Did you have a trauma to the breast that causes the tissue to be different? Did you have surgery on the breast electively or otherwise? So patients, like you had mentioned earlier, it's very easy to go to worst case scenario, but oftentimes the additional imaging is then negative and they go back to an annual mammogram. So a lot of what we do is counseling the patients to just kind of take a deep breath and get everything scheduled as fast as possible. You also, Dr. Heath, mentioned, being in charge, and I encourage all patients to be a steward of their own health. Post COVID, a lot of healthcare systems are short staffed or have difficulties answering the phone or returning calls. And I think it's very, very important to be a steward of your own health for your family members and for yourself.
Absolutely. And another question came in, and this is going to be relevant, I think, for all cancers that we discussed today. Should people have a second opinion?
I welcome all patients if they want a second opinion to go seek a second opinion. I would be hopeful that what I say to them is not vastly different from what they hear somewhere else. At the end of the day, you have to be comfortable with your provider. And it's not really about the name out on the front of the building. It's more about the relationship with the provider, whether it be the surgeon, the medical oncologist, or the radiation oncologist. And also word of mouth. I have a lot of patients that come to me through word of mouth because one of their family members had an experience or had a great experience through Karmanos. So I certainly tell them that it doesn't offend me at all because my hope would be they'd meet the second opinions. They would say the same thing and they'd come back to me because they had a better experience.
Great. And I know one of the things that came up a lot in prior discussions is sometimes mammograms are hard to interpret, so you got to go to the right person who reads them a lot. But a lot of women have dense breasts. So there's usually I don't know if we really know the answer. There are next steps, as sort of a major advancement that we have. Actually, the first machine in the world is the soft view machine. That is a different way to do breast screening, especially for those with dense breasts. That was a machine and a scientific sort of endeavor 20 years ago. So now it's come to fruition. I do believe we have a table outside, so if you have some questions, they're there, but I know that we have our first machine, I believe it's downtown. So learn more about that. Technology moves on. People know about mammograms, they're worried it's gonna hurt. I don't wanna do it, it's embarrassing. There's so many more techniques, including MRIs, as Dr. Richardson was mentioning. So let's say the patient has had a mastectomy with you, Dr. Richardson. What are your screening recommendations or follow-up recommendations after that patient has had mastectomy?
So it certainly matters if they've had bilateral mastectomy or only one-sided, because if they still have a contralateral normal breast, then we certainly have to keep monitoring that breast with annual mammogram. If they've had bilateral mastectomy without reconstruction, that means a simple mastectomy where there's no implant or any type of reconstruction. We counsel them about an annual clinical exam. So patients will often say, "Well, am I done with you?" And I say, "No." And they will usually follow with me once a year for 5 years. We'll do an annual clinical breast exam. They're often on some form of anti-hormone medication, depending on their type of breast cancer. So they'll follow with medical oncology. And then if they needed post-mastectomy radiation, then certainly they would continue to follow with radiation oncology. So it often depends on what led them to mastectomy and what other treatment they needed after surgery. But I continue to follow them once a year for 5 years. And I often describe myself as the captain of the ship. If they notice an abnormality or have anything they're concerned about, I'm the person that's usually going to take care of that in regards to additional imaging. With bilateral mastectomy, even with reconstruction, there is no indication for annual screening imaging, mammogram, ultrasound, MRI, unless they have a problem. So if all of a sudden a new nodule develops, oftentimes it's palpable and we can ultrasound that to see what it looks like. Is it scar tissue? Is it something new? Is it an issue with the implant? If they have a new lesion along the skin, sometimes that requires a punch biopsy or a skin biopsy. So I continue to follow them annually.
Now, that's, I think, great comfort to all of us that sometimes you feel that your treatment is done and then you're on your own. So I don't think that's the case for all cancers nowadays. We actually really want you to not fall out of follow-up, because that's when trouble happens. Um, I'd have this as the last question for you, Dr. Richardson, so we can stay on track. A question from the audience. Would you consider targeted therapy standard of care over chemotherapy? And is this something you make a decision on or weigh in on, or do you defer to the medical oncologist?
So oftentimes I'm the first person that the patient will see for their new diagnosis. So I try and lay out a roadmap of what's to come, whether that be chemotherapy first, followed by surgery or radiation. It may be just surgery and then radiation, but I try and plan for them and lay out a roadmap so they can have an idea of what to process when they go on to the next specialist. I think especially in breast cancer and multiple other cancers, this is a multidisciplinary approach. I do not work in a silo alone. I work with multiple other colleagues, and it's not just my opinion, although most surgeons will say their opinion matters the most. But it's not just my opinion, it's certainly the patient's opinion as well as the other providers. So if I think that there's somebody that would benefit from chemotherapy, I do make it a point to discuss that with the patient, because I always worry that they're going to go to the medical oncologist and then they're going to see chemotherapy and the patient's just going to stop listening. I mean, that happens. We see it as the provider where you mention mastectomy and you see the glazed over look in their eyes and you've kind of lost them for the rest of the discussion. So if I can be the quote unquote bearer of bad news sometimes and say, I do think you're going to be needing chemotherapy, I'll present that to them and then I'll send it to the medical oncologist and have them do the thorough discussion. I always tell my patients, I am the surgeon, your medical oncologist, your radiation oncologist, they're the specialists in that department. So I'm going to give you a brief overview, but they're going to go in depth to targeted therapy, chemotherapy, etc. And I always say, I don't want them to tell me how to do surgery. I don't want to tell them how to do chemotherapy or radiation. So, I think patients appreciate that approach. And then they're able to meet with the other colleagues with an open mind and not be so fearful of that consultation.
It's fantastic. So a round of applause for Dr. Richardson this morning. Thank you so much, Dr. Richardson. Wonderful. Well, I think we're going to stick with the Flint theme only because the other terrific resource we have in the state of Michigan is the Proton Center based out of Flint. And we're very fortunate today to have one of their experts, Dr. Christian Hyde, actually join us here. So Dr. Hyde, you are right there, yes? Come on up, Dr. Hyde. He is a radiation oncologist to keep the multidisciplinary theme going. And Dr. Hyde's going to tell us all about proton therapy. So keep your questions coming, guys.
All right, thank you, Dr. Heath. And thank you, Dr. Richardson. I just wanted to share what a great joy it is for me to get to work with Dr. Richardson every week. We both have offices in Flint, and when I see her patients, I'm always impressed at how well they've been prepared for the discussion about radiation therapy and what a great team player she is. So I wanted to talk about proton therapy, which is a major advance in radiation therapy. A lot of people come to me afraid based on the experiences that their mother or grandmother or grandfather had with radiation therapy. And a big part of the message that I have to convey is that this is not your grandfather's radiation therapy. You know, things have changed. We don't use the rotary dial phone like we used to. So every advance in robotics and imaging and computers, we apply it to radiation therapy to help cure cancer. So I'm in Flint at the Karmanos Cancer Institute there. It's a big investment, about $100 million facility that McLaren built and continues to expand. We're actually doubling our capacity as we speak. The center's being expanded. All right, next slide. So X-rays, almost everybody's familiar with X-rays. You know, you go to the dentist and they look at your teeth and see is there decay. And these were discovered over a century ago, back in 1985. And they were named X-rays because nobody knew what they were. They were unknown. And they're really important for imaging. You know, the beam goes in one side of your body and it goes out the other. That gives us information about what we're made of inside. And this picture is of the discoverer's wife's hand showing the wedding ring. And this is probably the most famous X-ray of all time. So we're pretty familiar with broken bones and the dental X-ray experience. Some of us have maybe even had a CAT scan, which is a three-dimensional X-ray where you go inside a tube or a donut, and as you move through it, it takes X-rays from all kinds of angles, and computers turn those into a three-dimensional image so we can see not just the bones, but also the heart, the lungs, all kinds of soft tissue. Next slide. Thank you. So X-ray therapy has been in use for about 100 years. It wasn't long after these rays were discovered that we started shining them at cancers and seeing that they almost magically would shrink. But the problem with the early X-ray machines were that they gave a lot of dose to the skin. And so patients would get more dose to the skin than they would to the tumor. And that meant that the treatment had to stop early when the skin started to get burned. It starts usually looking like a sunburn with some redness and some itching and some peeling, but it can progress to blisters. It can even progress into ulcers that can bleed. And that limited the curability of cancer. But advances occur with all technologies. With time, they get better. In the 50s, there was this cobalt machine that came out based on nuclear era technology, and it gave less skin dose than the old X-ray machines, but still much more than we give nowadays. So when people talk about their grandmother's experience or their dad's experience who was treated in the 70s or even sometimes the 80s or 90s, some of those patients were treated on cobalt machines. So it's important to realize that their results are not going to be your results. The modern linear accelerator, or LINAC, was invented in the 1950s. And this is a picture of a 2-year-old boy who was the first patient ever treated with the linear accelerator technology that was invented at Stanford. And since that time, it's been widely disseminated throughout the world. And one of the main companies that's still in Silicon Valley and makes these has sold over 4,000 units, and they're pretty much in every small town now. You can go to rural communities like Mount Pleasant and other small towns that will have one of these machines. But now that model is 10 years old. If you think about Motor City, every car gets redesigned, at least once in a decade. But there's not a lot of big redesigns coming for this technology. It's pretty much reached its apex. And the physics are unchanged since when these machines were invented in 1957. So X-rays, like I said, are great for imaging because the X-rays go in one side. They pass through tumors and other things we need to see, and they go out the other side where we can detect them. So it's great for imaging, but it means that if you're treating a tumor, that X-ray beam hits everything in front of the tumor and everything in back of the tumor as well. So a new technology was needed, and proton therapy is that technology. Protons are little particles. You can think of them like BBs that you can shoot into the tumor, and it will actually fill up the tumor one dot at a time until the tumor's been completely filled up with this energy that kills the cancer cells. And there's no exit dose out the back. So let's say you've got a tumor in the front of your chest, and it's right in front of the heart, and it's right in front of your esophagus, which is important for swallowing. The main side effects with conventional x-rays would be potential heart damage and painful swallowing, because that beam isn't going to stop until it goes out and hits the wall on the other side of the building. So if we can make the beam stop in the tumor before it goes into the heart, before it goes into the esophagus, that's really a benefit to the patient. It reduces their short-term side effects. It reduces their long-term side effects. And it's completely different physics that allows us to do this. Prior to the atomic age, this wasn't really possible because we didn't understand these particles. So it's really things based on like the theory of relativity that we use every day when controlling these particles. And so a proton comes from the center of the atom. It's a positively charged particle. And I like to say, think like a proton, be positive. These proton particles, we speed them up to half the speed of light. When they're going fast like that, they have a ton of energy. It's like a bowling ball hitting a pin and getting a strike. All the pins go down. So we want to hit that energy into the tumor. We want to kill it. We want to break those cancer cells in a way that they can no longer reproduce themselves. And that's what the protons do. So this is a picture of the front of the Proton Therapy Center. It's in Flint, Michigan. It's one of the biggest investments in Flint, Michigan, not just medically, but in total town recently. So it's a $100+ million investment in cancer care, and it's the largest single fixed investment that the Karmanos Cancer Institute has. We talk about the costs of immunotherapy and other new treatments. Proton therapy is also a huge investment and a leap forward because they're the first beam that can go deep and stop where we tell it to. So this is a patient that I treated for tonsil cancer, and the image might be a little fuzzy. The one that's kind of in multicolor shows a CT scan of his throat, and you can see this tonsil cancer outlined in red, and that's what we want to hit with the radiation beam, but we want to avoid the tongue, we want to avoid the opposite side of the throat, we want to avoid the vocal cords so there isn't hoarseness and painful swallowing, and we want to avoid the salivary glands so the patients don't get long-term problems with dry mouth and tooth decay. So this is a picture inside his throat going through treatment, and it was amazing to me that the beam really was stopping exactly where I told it to. It wasn't going across the midline. And if you can see, there's some redness and there's some peeling, but it's limited to the area of the tonsil, and then it stops very abruptly. It doesn't go onto the tongue. It doesn't go to the opposite side of the throat. We don't just use it, in one part of the body. This is a technology we can use in all parts of the body. One of the biggest areas of improvement is when we're treating the liver. Patients who have liver tumors are often sick because you need your liver to survive, and if it stops working, that's it. You don't get another liver usually if you have cancer. So these large tumors are usually inoperable. A surgeon cannot take them out without sacrificing the whole liver. And if we use conventional x-rays that go in one side and out the other, they're going to be damaging 2 to 3 times as much liver as if we were using protons. So there's actually been a study that looked at this, and they looked at patients who were treated with x-rays and compared it to patients who were treated with protons. What they found was that the proton-treated patients were surviving longer because they had less liver damage. It was actually liver failure that was leading to their death. And it's not to say that the x-rays were killing them, but side effects do make a difference. We talked about the esophagus. It's very radiation sensitive. When it has cancer, sometimes it will actually block the esophagus, one of the first symptoms, if you find that you can't swallow steak anymore and stuff starts coming up, that could be due to narrowing of the esophagus, either due to scar tissue or sometimes due to a tumor. So you got to get that checked out by your doctor. There was recently a big result published out of MD Anderson in Texas where they compared a randomized trial. That's where half the patients get one treatment, half the patients get the other. Patients and their doctors don't choose. But this is really important when we're trying to evaluate a new technology. We'll compare the old standard and the new option. So half the patients got protons, half the patients got x-rays, and they found that after surgery to take out the esophagus, there were more complications in the patients who were treated with x-rays. Some of those complications were pneumonias. Some were when the patients were in the ICU, they would take out the tube that the patients were breathing with. And after that happened, they would have to put the tube in more often in the patients who had the x-ray therapy because their lungs were more inflamed. They had trouble getting off the ventilator. Another thing they found was increased cardiac rhythm abnormalities. Oftentimes after radiation, we think about it causing premature coronary artery narrowing, and we weren't really aware of it causing things like atrial fibrillation, but it can. And they found that more commonly in the patients who got x-rays. There were even some treatment-related deaths in the x-ray arm that they did not see in the proton therapy arm. So this has been expanded. It's now undergoing a nationwide trial. The first one was just at a major cancer center. The next one is nationwide, and we're actually participating in it, and it recently opened so that we're able to offer patients here in Michigan the same comparison and see, is this not just one institution's finding, or is this reproducible nationwide, maybe even globally? And part of that is because proton therapy is a big investment. We want to make sure the patients are getting their money's worth, and that if they're traveling to Flint every day, that they're getting the full benefit of the technology. So thank you, Dr. Richardson, for talking about breast cancer and the role of radiation therapy in breast cancer. One of the things that I really was personally drawn to in radiation oncology when I was in medical school was that we could prevent the need for radical surgery sometimes. We saw the pictures of some patients who had really disfiguring surgeries, and most patients want to keep their body in one piece if they can, and radiation therapy really helps me to do that. Helps patients avoid losing their tongue from tongue cancer, losing their voice box from voice box cancers, and things like that. So we've learned, though, that radiation can be a double-edged sword, and this was a big study from about 10 years ago in kind of the nation's premier medical journal, the New England Journal of Medicine, and they showed that there is basically no safe radiation dose to the heart. We used to think, when I was in training at UCLA 20 years ago, that as long as you only gave so much, it was going to be okay. But we really found that it's kind of like poison. Sometimes you really can't find a safe dose. So the way that we spare these organs is really important. My job is really simple. I'm kind of single-minded. I just try to pack as much radiation into the tumor as possible and as little to the rest of the body as humanly possible. So anyway, since this big study in 2013, we've known that there's increased risk of heart attacks and stents, angioplasties, and even some cardiac deaths in these women where we radiate, particularly the left breast, because the beam can go through the heart and not just the breast. And these things show up years later, sometimes 3, 4, 5, 6, 7, 10, 20, 30 years later. And so there's a clinical trial going on now that is looking particularly for patients that need lymph node radiation, where we have to treat a bigger area up by the collarbone, down near the ribs, where there are some lymph nodes. And we have to see, are we causing heart attacks, and can we prevent them with radiation treatment? And we know that mathematically, the models say that we are, but does it actually pan out in human beings? Because sometimes the mathematical models are not the same as what's actually happening in the patient's body. So these patients have to be willing to get x-rays or protons. Some patients aren't willing to accept that risk based on what we know already, but we are looking at what is the benefit to cardiac sparing, what is the benefit to skin sparing. And you can kind of see in this example, there's this beam of X-rays that would normally cut across the heart at an angle, but we don't do that with the protons. We can carve the proton dose in a way that we can't carve the X-ray dose. One of the other things that we worry about long-term risk, even decades after radiation, is are we actually creating or planting the seeds of another cancer that might show up 20, 30 years down the road? And this is because radiation isn't health food. You know, whenever you go in the hospital, if you're going into a radiation area, you're going to see this sign that X-rays are in use or that there's potential radiation exposure. And this is why when you go to the dentist, they put on the lead vest, and the hygienist goes out of the room. You know, they push the button, you hear a noise, then they come back in when the X-rays are gone. So radiation isn't health food. Just like heart disease, it takes time for this to show up. And the best prevention is by limiting the dose of radiation. The least radiation is the best radiation, which is why I went back to school to study proton therapy. So proton therapy has been studied, and it's been found to show 69% less chance of second cancers compared to X-ray therapy. And it doesn't matter whether that's old X-ray therapy for 20 years ago or newer forms of X-ray therapy from 5 or 10 years ago. And why is this? It's because the protons stop where we tell them to. They don't keep going, and they don't keep damaging other areas of the body that may, years down the road, lead to another form of cancer. I wanted to let you know we are applying it for other areas of the body. This is a slice of a CAT scan through the patient's abdomen. You can see a couple of landmarks like the kidneys toward the back. That white area is the spine. And this is a pancreatic tumor. We know that pancreatic cancer is a serious illness. It's increasing in prevalence as people are living longer. And yet, usually by the time it's found, it's too late to take out surgically. This is because early on in the pancreatic cancer's growth, it will stick to major arteries and veins that we cannot cut out, or the patient will die. And so we need a non-invasive treatment for a lot of these patients. Usually it's chemotherapy, but chemo isn't always enough to control a visible chunk of tumor. It's really effective against microscopic disease, and it's very good at shrinking visible tumor, but not always completely curing it. And in sometimes patients will have had surgery, but there can be microscopic tumors that maybe the surgeon can completely get out, and those will regrow over time. So I've been treating patients where their pancreatic cancer comes back after optimal surgery and after optimal chemotherapy when they're starting to run out of options. So the nice advantage of proton therapy in these patients is that the beam goes in through the back. It doesn't exit out through the stomach or the intestines. We don't have to bring it in through the liver and do a lot of damage to the immune system. So this is another clinical trial that we're opening soon at the Proton Therapy Center. One last thing I wanted to talk about is that we've used proton therapy for kids quite a bit. They're developing, their bodies are small. It really matters how much of a kid's body you radiate, because they're going to grow, and the damage that you do when they're 3, they're going to be living with for the next 80 years. So we've been using it for pediatric tumors, and we've treated kids as young as 4 years old up at the Proton Center. And in some tumors, we have to treat a really big area. So the tumor might start, just at like the base of the brain, but some of those tumors will spread through the fluid that surrounds the brain, and also the fluid that goes down into the back and surrounds the spinal cord. So we want a beam that will go into the spinal cord area and stop, and not go out through the heart and the lungs and the stomach and the esophagus and all these other organs that are sensitive to radiation. So with protons, you can see that the beam goes in where it's orange and red, stops in the vertebral body or the spine, and it doesn't keep traveling. And compare that to the old days, which is still the case in most parts of the world and even places in the US, where the beam just goes in the back and keeps on trucking out the front. So I wanted to highlight a result from this summer. There's always a big conference in Chicago where all the medical oncologists like Dr. Heath and her colleagues go to learn about new advances. And this was one of the big radiation advances that showed if we radiate, not just in kids, but in adults who have breast cancer and lung cancer that has spread around the brain and around the spinal cord, that if we give radiation using proton therapy, we can treat all of that area at risk. We can sterilize not just the visible tumor, but also the microscopic cells that are floating through the fluid around the brain and the spinal cord, and we can actually keep patients alive much longer than we could otherwise. The average age of or length of survival for those patients is only about 6 months once the cancer gets into that fluid. But we were able to extend that, not quite double, but by 4 months. And usually 4 months, if a drug makes a 4-month survival, that's like front page of the New York Times. This is a treatment that's been around for decades that we're now able to apply for this really incurable illness. I also wanted to mention that proton therapy will probably be used more and more in the future as immunotherapy becomes more common. We know that these drugs, you know, the Opdivos, the Keytrudas of the world, that the vendors out in the hallways are happy to educate you on, these don't kill cancer cells by themselves. They're fundamentally different from radiation and chemotherapy. Radiation and chemo kill the cancer cells directly, but the immunotherapy only kills the cancer cells by way of the white blood cells. And if you don't have enough white blood cells, particularly ones called lymphocytes, the immunotherapy is not going to work well. And we know that the lymphocytes are extremely sensitive to radiation therapy. Even just one dose of, like 1 day's dose of radiation out of like a 6-week course can almost kill half of the lymphocytes in that area where you're shining the beam. So it's really important to reduce the total amount of radiation going into the body to maintain the patient's white blood counts, especially the lymphocytes. And so by reducing this whole body dose, what we call the integral dose, we're able to better spare the patient's blood counts, including the lymphocytes. And this is what a lymphocyte looks like under the microscope. So just like Dr. Richardson was talking about, you know, it's hard to tell up front who's going to need what sort of treatment. It really takes a team of specialists, not just, you know, a surgeon working in isolation or a chemotherapy specialist in isolation, but it's really a team effort. And I wanted to share with you some of my team players who are with me up at the Proton Therapy Center in Flint. We're all very experienced now at delivering proton therapy. 2 of us have done fellowships. Dr. Ye, he did his fellowship at MD Anderson and practiced in New York for a while before joining us in Flint. We do have a nurse navigator who's very good at getting patients in. We have a 1-800 number, 855, my proton number, that can get patients in touch with the navigator, and she helps them through the treatment process, which can be really kind of intimidating, especially if it means travel. Fortunately, we're lucky in Flint. We have this beautiful place called the Hospitality House that's actually just about 100 yards by foot from the Proton Center. And I often park my car over at the Hospitality House because the Proton Center parking lot is so full nowadays. But patients who need to stay there, it's just $35 a night. I even stayed there once because it snowed like 7 inches overnight. And I'm like, I'm not driving through that. So anyway, in conclusion, I just wanted to add that we're very blessed and fortunate to have this resource in our community. It's a long-term visionary approach to decide to build a proton center. It's, you know, we're in a casino ballroom here. It's a huge gamble to, you know, put down $100 million on black and say we're taking this all the way. So I'm fortunate to work with some visionary people who did that 10 years ago, and now we're seeing the fruit of it. Yes, ma'am. Yeah, great question. So a question from the audience is, if radiation kills white blood cells, you know, what happens? Do they renew? Do they come back? The answer is yes, as long as we don't kill all of the body's blood producing cells in the bone marrow, those counts do come back. But there's kind of a window of opportunity. We have to make sure that during that window of opportunity, while the patient's going through immunotherapy or chemotherapy, they have enough immune cells not only to fight the cancer, but also to fight infections.
Can you guys hear me? Whoa. Okay, sorry about that. Woke everybody right up. I'm going to leave Dr. Hyde on the stage. First of all, let's give him a huge round of applause for this amazing lecture. Yeah. Let me just take a poll real quick. Who's ever heard of proton therapy as a possible treatment? Okay, right there, Dr. Hyde tells you that the whole room should have raised their hand. So part of events like this is for you guys to learn about new technology. This can't get any more cutting edge than what he's described. So to know that this resource exists right in our backyard, I think it's at least worth a conversation with your team, with your provider. Again, it can't get any easier than 855 MyProton. So, you know, and I've referred plenty of patients there. The experience is really wonderful. Whether it's right for you or not, it should be a part of the discussion. And I think that's always the missing piece. You feel like you're a little bit gypped when you don't know something. So part of today's mission is learn everything, spread the word, because we're very fortunate in the state of Michigan that we have this. I mean, lots of other states have to travel in to do this. So I think there's a question also from the chat. Do you see that this proton therapy has taken over the RFA program or protocols or procedures? So I think the other part is, and we're going to learn a little bit more today about cryotherapy, which is freezing. RFA is a different type of radiation. Where do you think that all fits in, Dr. Hyde?
Yeah, so I think it's important to recognize that there is no single best option for all cancers. And it really depends on the specifics of your particular type. You know, there's like 100 different chemotherapies now. And if I reach into my radiation toolbox, proton therapy is not the only answer. So we're a complement to lots of other treatments. Just because we have proton therapy doesn't mean we can always get rid of surgery or chemo. In fact, oftentimes the best approach is to use a little bit of each instead of tons of one and none of the other. So we've not replaced other interventions for liver tumors, but we are carving out a niche where we can help people where we used to not be able to help them.
Oh, that's a great question. I guess that also leads to the next one from the chat, which is, are there folks who shouldn't get protons? Are there folks that are really contraindicated in terms of this procedure?
So I can't think of anyone who's contraindicated, but I can think of some patients who don't benefit a tremendous amount. So for example, one of the treatments when a patient has tons and tons of tumors in the brain, like let's say someone had 50 tumors in the brain and they can't get spot treatment for those patients, we literally treat the whole brain. And it doesn't matter whether you're using x-rays or proton beams. In that situation, you really end up having to treat the whole brain. And there's nothing to spare. So for those patients, it's not going to make a difference. It's not going to be worth the trip.
And I think that's the important part, that if it's not going to be the right fit, you and your team would share that information. It isn't because they have this tool, they're going to do it. Is the role of proton in pancreatic cancer radiation sort of becoming the lead in this, or is traditional radiation still very much in the picture?
Yeah, so traditional radiation has largely fallen out of the picture for pancreatic cancer, and I think part of the reason is side effects. In order to show a benefit, you have to have enough healthy cells left over that you're not, doing more harm than good. And I think in the past, maybe for pancreatic cancer, we were doing more harm than good because it's not easy to take radiation to the stomach. There's lots of nausea and vomiting. You can get diarrhea from small intestine radiation. So you really have to be judicious in where you're applying these tools.
Yeah, I'm getting yelled at to stand up here. That's how, I'm too short. No one can see me. That's fabulous. We're going to have to, and just for the record, there's an actual stool here that Dr. Hyde has had to go over. So full disclosure. I think the other question is, what type of cancers should proton be a consideration for? Is it all types?
So that's a great question. We are still learning the indications for proton therapy. In the beginning, people said it's a great tool for kids, and everyone kind of agreed on that. And then people said, well, what about breast cancer? And we're starting to see, it's making a big difference in how much dose we give to the heart for breast cancer. And then other people are like, well, what about liver tumors? And what about brain tumors? And what about, and the indications keep growing and growing. The longer we have these tools, the more we find uses for them. So it's not static, these are the only indications. it's an expanding list.
Okay, last question. Oh, wow, there's lots of questions. I know one of the questions that always comes up for my patients are, will insurance cover this?
Great question. So people often think of this new technology as being somehow experimental, but we've been using it in the country actually since the 1950s. And it was FDA approved in 1988, and it's a standard Medicare benefit. The VA covers it for most cancer types. So it's really pretty well recognized among the payers, unless they don't want to pay.
And I can say that also there's a great process. If you're denied, there's an appeals and there's a team in place to go through that, so you wouldn't be alone. I know there's a few more questions. I'm afraid we're getting close to time, but maybe one more or two more. How about that? Go ahead.
Yeah. So the question from the audience was, in 2017, if you had a cancer diagnosis, would this have been an option? And the answer is, in Michigan, no. It probably wouldn't have. There was one center, Beaumont opened around 2017,
Yeah.
McLaren opened around 2018, 2019, but those are the only two facilities in the state.
Yeah. Okay, that was your question. One last one. So is
Yeah.
proton a standalone, Dr. Hyde?
So the question specifically for breast cancer is, you still have to have the visible cancer removed. And then we radiate to kind of mop up any microscopic cancer cells that might be left behind. There are some tumors where we use this as an alternative to surgery, but sometimes we use it as what we call an adjunct in order to help make the surgery more effective.
Yeah.
And I thank you all for your attention, and I'm sorry that's all the time, but I'm sitting here in the audience if you want to approach me later.
Yes, everybody accost Dr. Hyde later. Let's give him a round of applause. Thank you so much, Dr. Hyde. Really just amazing how the technology has increased. Am I completely messing up this audio, guys? You're good. Okay. So to move on, I'm really just thrilled to announce that there's a new location in Lansing. I know we said hello to them this morning. Very jealous down in Detroit because their new cancer center is state of the art. And we're very lucky to have Dr. Craig Cole, who's going to give us an update today on multiple myeloma. I know we've had a few discussions now on solid cancers, but liquid tumor cancers also unfortunately plague our community. So we're going to now switch over to Lansing, and hopefully, Dr. Cole, you are available. Is he on screen?
I am available. So, well, thanks for inviting me. And I was really excited to hear the theme of the meeting today being then and now. Having studied medical history, I'm a medical history buff, and myeloma has a remarkable history. So I love James Baldwin. I love a lot of the books that he's written, and I think that is very appropriate with his quote that says, "Know where whence you came. If you know whence you came, then there's absolutely no limitations of where you can go," which I think is very appropriate for today's talk. So we're going to go way back to Great Britain in 1843. One of the first patients that have ever been described with multiple myeloma was Thomas McBean. And he was a grocer and a businessman in England. And he was experiencing more and more fatigue, and he was beginning to have a stoop when he walked. And he was only 43, so he was a young man at the time. And then he went on vacation, and when he was hiking and actually hiking up a hill in the countryside, he felt instantly something snap in his chest, and he lay in agony, unable to stir. He then went to one of my heroes, Dr. William McIntyre, who was really I shouldn't say just, but he was a family physician in London, and he saw him, and Dr. McIntyre examined him and applied a strengthening plaster. But he really examined Mr. McBean and found that where his urine had touched his linen, that it was stiffened. And so Dr. McIntyre was like, this guy his bones are softening, but he has this hardening substance in his urine. And so he kind of filed that away and applied the strengthening plaster. And then 1 month later, Mr. McBean returns to Dr. McIntyre, and he gets really the standard of care at that time, which was removal of a pound of blood to balance the humors, because that was the science at the time, and an application of leeches. And if my wife is watching, I want that leech thing in our house. But I wouldn't put leeches in it, honest, maybe. So then the following year, Mr. McBean goes back to Dr. McIntyre, again with bone pain, and this time leg swelling. And Dr. McIntyre was like, this is the guy with the softening bones that has the stiffening, starchy stuff in his urine. So Dr. McIntyre examined his urine. Now, remember, this is just a regular physician, but he was curious. And that is what made all the difference. And he saw the urine and then wrote to Dr. Henry Binns-Jones in London. We'll talk about him in a second. And what he said is that the tube of urine that he sent to Dr. Jones has a high specific gravity. And when boiled, it becomes opaque. And when it cools, it clears up, and heat will reliquefy. And at the bottom, there was this substance. And again, Dr. McIntyre was, what is it? He's putting something in his urine, but his bones are softening. What is this substance? So Dr. Henry Binns-Jones, he wears a bow tie. That's why I wear a bow tie. He's my true hero. And he was the grandson of an Anglican priest. His mom wanted him to become a priest, but he wanted to become a physician. And so he went to medical school. He then had rheumatic fever in medical school. So he had to drop out of medical school. And his mom was like, I told you so. And he's like, I got other plans. And he actually went to chemistry school in Germany and spent 2 years there recovering from his rheumatic fever. And he learned about science, because medicine at the time was application of leeches and balancing the humors. So Dr. Jones is learning about science, and then he returns fully healed, got his degree, and he starts to really use the only chemical that was available to him was urine. And he dedicated his life to expanding medical knowledge through science. And there's this is his apartment, and he lived on the second floor. He'd wake up at 6 a.m. in the morning, every morning, doing experiments on urine. And everybody knew him as the chemical doctor. And he pushed science instead of the balancing of the humors. And actually, he lived with his 3 children in a second floor apartment. He would do his experiments at 7 a.m. until noon. So you can imagine that his apartment's full of urine all over London. And so as soon as this starts to heat up, because there was no air conditioning back then he goes to his wife and says, I got to go around. I'll see you later. Bless her heart. So really, she's my hero, because she's put up with Dr. Jones. But when he got the urine from Dr. McIntyre, he found this hydrated peroxide of albumin and wrote back that I need hardly remark on the importance of seeking this oxide of albumin in other cases of maltese osseum, a softening of the bone. That was the first, the Binns-Jones protein was then discovered. And that was the first biochemical test for cancer detection. So now people that had osteoporosis and that had sort of natural softening of the bones, you're able to distinguish that from the people that had this malignancy. So Dr. Jones saw Mr. McBean, and when he came into the hospital with a pain crisis, and they did everything that they could at the time, including iron and quinine, opiates. They actually gave him mutton chop, and he finally died of exhaustion. And the cause of death that was on his death certificate was atrophy from albuminuria. And to this day, which I think is very interesting, one of the ICD-10 codes for myeloma is myelopathy of albuminuria, which is a throwback to this diagnosis that was made in 1844. They took an autopsy of Mr. McBain, and with Dr. Jones and Mr. Shaw, who was the autopsyist, and they found that his bones were soft and brittle, could readily be broken, and that the interior of his ribs were soft and had this jelliform substance. And that is a carving that was made of the cells that they saw, that they felt to be the cells, the suspect cells causing the cancer. The most important thing is that they wrote about this, that this family physician in London didn't just say, whatever. He said, I think people should know about this. So they wrote a paper, and that paper changed the world. In 1894, X-rays were invented, and there's again one of the famous X-rays that were first done. And then Dr. J.H. Wright had read the paper that was done just a few years ago by Dr. McIntyre and said, I see a patient with this. So he actually used this X-ray technology to find, this is one of the first X-rays of a myeloma patient that was taken, of Dr. Wright's patient. And this is one of the first photographs of a myeloma bone marrow, where you can see the plasma cells and the blood vessels that are running through it, which made this a very different cancer from anything else that people had seen. And because plasma cells had been described a couple of years earlier, they identified these as plasma cells and said that myeloma should be regarded as a neoplasm originating one of the varieties of the red marrow, i.e. the plasma cells. And their idea was that the substance of the bone is being dissolved by the myeloma cells, put in the blood and excreted in the urine, which is really pretty much what we see today with myeloma. An interesting twist was that there was really no therapy. So we had described it, but there was no therapy for myeloma. And interestingly enough, the guy that invented dialysis had a patient that had Binch-Jones protein in his urine, was actually on dialysis, and the dialysis doctor said, I think I'm going to give him urethane to see if this will help. And urethane was a plant killer, uses a coating, adhesive, and sealant, and I have no idea why he picked urethane to give his patient. But it actually, he wrote that it helped this patient, that his protein went down, the Binch-Jones protein went down, and however the patient then subsequently died. But based on this one paper, for almost 20 years, urethane was the standard of care for myeloma back in from 47 to 66, until there was a randomized trial between Coca-Cola, actually Cherry Coke, and urethane, one of the first randomized trial in myeloma. And who do you think won that battle? Coca-Cola. So that there was no difference in overall survival or in response. And so that was very important for us to know what works and what doesn't work. It was the beginning of clinical trials for myeloma. So what is myeloma? Well, inside the bone marrow, there are plasma cells. And when those plasma cells become mutated, they become myeloma cells. So they still have a lot of the activity of what normal plasma cells do, that they produce excessive amounts of antibody in the immune system, drowning out the normal immune system. And these antibodies, these monoclonal proteins, is what Dr. Binch-Jones was detecting in 1844 in that hydrated dioxide of albumin. Myeloma, again, is a blood cancer. It grows out, and actually it forces out the normal bone marrow forming cells, which can cause anemia and cause people to feel tired and fatigued. It will go to the bones and cause weakening of the bones, like we saw with the case of J.H. Wright and poor Thomas McBain, who had fractured his sternum. And when the myeloma cells go to the bone, it begins to dissolve parts of the bone, releasing calcium into the bloodstream. Again, as we know from Dr. McIntyre, Dr. Jones, and the doctor that used urethane, it can get stuck in the kidneys. And we use the mnemonic crab to remind us of the signs and symptoms of multiple myeloma. Some of the fast facts about myeloma: it's the second most common blood cancer. There were 34,000 new cases in 2022. And we'll get back to this. An important statistic is that there are 138,415 patients now living with myeloma in 2021. It is most frequently in adults. As I get older, older people is like 100 years old. Adults are between 50 and 70. And interesting enough, and we still are doing a lot of research to figure this out, that the incidence of people of African descent is higher than all other races, and that is around the world, and we still don't know why there is that disparity. This slide contains research done in the laboratory for over 30 years. And it's a complicated slide, but it shows that we have an understanding of the biology of myeloma now. We used to use chemotherapy to treat myeloma, and it was ineffective. Obviously, urethane didn't work, Coca-Cola didn't work, but chemotherapy did not work well for myeloma until we had an understanding of the biology of myeloma. And we developed drugs to target the myeloma cell biology. And among those are the proteasome inhibitors, one of which is Velcade, we'll talk about in a second, and the immunomodulatory drugs, the IMiDs, including thalidomide, Revlimid, and Pomalyst. And I would love to talk to you about the story of how thalidomide came to myeloma one day. So invite me back next year and I'll give you some more history. Now we know about the surface proteins on myeloma cells. The surface proteins have the address that identifies the myeloma cell from all the other cells in the body. In those address cells, we have now developed targeted therapy that picks out the myeloma cells specifically and can kill them, including antibodies directed towards SLAM7 like elotuzumab, the antibodies directed towards CD38 that's specifically on plasma cells, daratumumab and Darzalex Faspro and isatuximab, and then the therapies directed towards BCMA. Which is only, again, on those plasma cells. And so these new immune therapies that destroy the myeloma cells really are revolutionary. And it's because, again, we have an understanding of the science. So we've applied that to patients by dividing the treatment regimens of myeloma into frontline treatment, maintenance therapy, and relapse therapy. And we have a number of different options. So when a patient comes to me with newly diagnosed myeloma, we go through the options. It's just not one therapy for each myeloma patient. We now have a variety of different therapies to offer patients. And for years, for the past, I would say 15 years, it's been the Revlimid, Velcade, and dexamethasone has been our main induction therapy, but there have been some changes I'll talk about in a second. We then follow that up with either stem cell transplant or continued induction therapy, with our preference having patients who are eligible to undergo stem cell transplant, followed by maintenance therapy. Dr. Bartologhi at the University of Arkansas taught us decades ago, that maintaining patients on therapy increases their progression-free survival and how long that they survive with the disease. We can't cure myeloma yet. And when it comes back, then we use rescue therapies for relapse disease. And that's when the playbook opens wide, that we have a number of different treatments. And I don't know if you can see that every year we've had one or two new therapies that have been approved for relapse and refractory myeloma, which helps our patients greatly. And every bar you see has clinical trials, because there's always clinical trials available for our patients. And those clinical trials have yielded incredible results. And we'll talk about how Dara-RVD, that was at first in clinical trials, has now become the standard of care. So I kind of gave it away already. But the Griffin trial, these are results that were presented at the International Myeloma Society meeting in August. And this is a trial that got newly diagnosed patients with myeloma and then randomized them between the best standard of care therapy at the time, which is Revlimid, Velcade, and dexamethasone, those targeted therapies that I talked about earlier, versus adding one new drug. So one important point that I want to talk about clinical trials is that when patients are on clinical trials, they will receive the best available therapy that they would receive anyway, or they receive the best available therapy with a little something else, the investigational agent. So there should not be fear of randomization because you'll always get the best therapy. So patients either got RVD or the addition of daratumumab, that drug that targets the address of the plasma cells, followed by stem cell transplant, followed by consolidation. So after you beat up the myeloma cell with your RVD or dara-RVD, left hook with the stem cell transplant, then you beat the disease down further with consolidation, and then you maintain them on maintenance therapy like we had talked about, the treatment sequence of myeloma. So how did that work out? So RVD, really good response rates. That's what we've been doing for the past 15 years. 91% response rate for newly diagnosed myeloma. And you can see that a lot of those were those deep responses. A VGPR means that 90% of that protein produced by the myeloma cells had decreased or was gone. And a complete response means that the protein can't be detected by the laboratory test. So 100% of the protein had disappeared using treatment. A lot of good complete responses and very good partial responses. But when you compare that to the dara-RVD, adding that extra drug that targets the myeloma cells specifically, you add that on, the response rate's 99%. And if you ask me when I had hair and a high top fade, would you ever, Craig, would you ever see, get a haircut, Craig, but would you ever see a response rate of 99% in myeloma? I would say that's impossible. Nothing. My blood pressure medication doesn't work 99% of the time. 99%. And look how a lot of those were deep responses, those 90% and greater responses. Incredible response rate by adding on that extra drug. And it was, of course, it was statistically significant. And just in August, the announcement was made that the results of this trial that patients were part of, patients is what made this happen. Patients showed on this trial that there was a progression-free survival benefit favoring the investigational arm with a 55% reduction in progression or death of myeloma. An incredible, incredible result. And the authors said that this data supports that our dara-RVD induction and consolidation is the new standard of care of myeloma. And again, which has really, after 15 years of using the same therapy, this is the paradigm shift that we were looking for. So when you look back through time, when we first started doing myeloma therapy, of course, urethane didn't work out so well. So who knows how well it responded. Methylprednisolone was a standard of care from 1968 after urethane up until about 2003. And again, when I had, high top fade, and that was pretty cool back then. The best responses that I could tell patients is a 35% chance that these pills, these chemotherapy pills would work. But when we introduced those new therapies, when we introduced the thalidomides, the Velcades, those targeted therapies that I had just mentioned, look at those response rates jump up. They double from the old days of chemotherapy. And then when we added on, use these drugs in triplet form, when we combined them together, again, another paradigm shift as responses were even greater. And then finally, oh my goodness, 100% response rate, 90% response rate, 99, 92% response rates. And the best thing is that the quality of those responses was way deeper than what we were able to achieve. Where I can tell a patient, you will have 90% of the time, you will have 90% or greater of your disease gone by the time that we finish this therapy, which is, again, an achievement of the doctor-patient relationship. Because those numbers that I put on there are because patients were involved in clinical trials, and those patients then made that paradigm shift to help other patients continue on until we cure this disease. So with these new biologic-based therapies, using 3 and 4 drug regimens, now the response rates are 99% as opposed to 30%. We have been very blessed in the past few years to have 31 drugs approved by the FDA for myeloma, and we're anticipating a new delivery any day now that will also shift the paradigm in treatment of myeloma. With these novel therapies, these targeted therapies, they're targeted to the address of the myeloma cell so they know exactly where to go, and they attack the biology of the disease. We've seen dramatic changes from patients living really 2 to 4 years up to greater than 9 years. Patients ask me, how long do I have to live with this disease? I say, I don't know, because the technology is constantly changing. When you've had 31 drugs approved in your cancer and it keeps advancing the disease, it is unclear of how long anyone has to live because nothing is static in myeloma. The 10-year relative survival rate has doubled in the past 20 years. And this is my favorite part of the presentation, is that, again, I think I was losing my hair in 2004. So in 2004, there were only 54,000 people living with this disease. And in the subsequent years, as we've done more research, had better therapies, the number of patients has been climbing. Not because the incidence is going up that high, but because people are surviving the disease. And so now that, again, remember that number, 138,000 people living with this disease, and it just keeps on going up because myeloma is not curable yet. And I think every myeloma doctor I know anticipates that cure is going to come soon because we just keep getting better and better, and patients are helping us treat myeloma better and better every year. But it is survivable now. And so when Dr. McIntyre wrote that paper about Mr. McBean, at the very end, these are the last lines of that paper that he wrote. He said that I shall be content if I have succeeded in pointing out to future observers, conducting researches of a higher order, hitherto unrecorded pathologic condition that may be recognized and identified. I love this man. I love this man. He is awesome. So thank you very much. I'll take
Thank you
any
so
questions.
much. Let's a round of applause for Dr. Cole. I hear your cheering section there, Dr. Cole, so glad to hear the Lansing crew is robust, alive, and well. Dr. Cole, I think we're going to vote you as historian, period, because that was a really amazing presentation. We do have a question from the chat. What are your thoughts on smoldering myeloma? Is there a cure for that? What should a patient expect in terms of anemia and the natural history of smoldering? I can't even get smoldering myeloma.
Yeah, that's such a good question because that's another area that has been changing and evolving rapidly in myeloma research. Before we would just observe smoldering myeloma, and smoldering myeloma should clarify, we talked about those CRAB criteria in myeloma and those symptoms of when patients have the hypercalcemia, renal insufficiency, anemia, and bone disease. Well, sometimes patients will present because they've had just some insurance labs done, or they have had some fatigue and their doctors check labs, and they pick up this extra blood protein, this monoclonal protein, and they have no symptoms. And when we do a bone marrow, we see those plasma cells in the bone marrow, and that's called smoldering myeloma. No symptoms, no signs, completely silent, but it's smoldering underneath the waves. Before, we would just observe, and there wasn't much discussion about it. Now we have clinical trials and clinical trials. Previously, only 6% of myeloma papers were written about smoldering myeloma, and that's exploded dramatically. And so now our first choice is to enroll patients on clinical trials. And we're doing research here in the lab that we have here and looking at understanding the biology of smoldering myeloma, because smoldering we think has a different biology than true multiple myeloma when patients have lots of symptoms. We want to be able to look in those plasma cells and try to delineate what causes people to go from that smoldering stage into the full-blown myeloma stage. So being involved in clinical trials, I think, is the big thing. And also there are criteria to tell you, could this actually turn into true myeloma? And so if the protein goes up and up and up and up, you have to really wonder, am I going to start having those symptoms? And if the hemoglobin starts to go down and down and down and down, we call that evolving type smoldering myeloma, and seriously consider doing treatment for those folks, because the chance of them having true symptomatic myeloma in the following 2 years is much higher than if someone has stable lab counts.
Thank you so much. Another question is, can you comment on a stem cell transplant? What does that mean? And is that something that should be part of the treatment plan?
That is, I'm smiling because that's such a good question. So a stem cell transplant, I think I mentioned the whole boxing thing, that when we're treating myeloma is like using the right hook. And I don't know much about boxing, I'll be honest, but you're punching the bad guy, the myeloma, with the right hand with that DARA RVD. And they're starting to kind of buckle. And then if you want to knock them out, use a left upper hook. So you use that chemotherapy. I said chemotherapy doesn't work for myeloma, but when the disease is wavering and about to go out, using one dose of chemotherapy that's high enough where you get the stem cells from the patient, you save it away, you do that left upper hook with chemotherapy, and in order to rescue the patient from bad side effects, you give them their stem cells back. So you do the 1-2 punch, knock the bad guy out, and that's a stem cell transplant in brief. There was just announced the results of the determination trial, which randomized patients, beautiful trial, but it had patients either going through stem cell transplant or observation, or continued therapy, which again is a standard of care. And patients had undergone transplant or continued therapy without going through transplant. And that was resulted earlier this year, which showed that patients that had transplant had a longer time for them to relapse than if they didn't have that. Another study in the IFM that was done years prior to that showed that if you can get the transplant later if you wish, and that there was no harm in doing that. But it appears that stem cell transplant will lengthen the time, that right hook and then left upper hook lengthens the time until relapse with multiple myeloma for patients that are eligible for stem cell transplant.
That's fantastic. I think the fact that you showed the early days of how this cancer was treated to where we are today, it's just phenomenal. But it does really lend itself to our next question, which is, there's a lot of cancers we're talking about today that have a disparity that remains unacceptable today. Obviously, breast cancer is one, and so many other cancers. How do you think we as a community should engage more African Americans into participation of clinical trials?
That is a fantastic question. We now know, and that the number of African Americans, because I showed you earlier how African Americans are affected by myeloma at double the rate that Caucasians and other races are. And it's really important for us to know that these therapies work equally between the races, because obviously if myeloma occurs in African Americans at twice the amount of Caucasians, that there's something different about African Americans that have myeloma. And Asians people of Asian descent have a very low incidence of myeloma, lower than any other race. So there are biologic differences, and you want to make sure these treatments work well for everybody. So there's been a great effort to enroll diverse populations in all cancer clinical trials, but especially myeloma because of that disparity. The big way to alleviate that is make awareness of the importance of clinical trials, how being involved, being an African American or being an Asian or being a Latino person involved in clinical trials not only helps you being involved in clinical trials, but helps your community being involved in clinical trials. Clinical trials are safer than they've ever been. The FDA has really been completely remodeled in order to ensure safety and equity in clinical trials. And so I think the biggest thing is really to tell our patients and to tell our neighbors and to tell our friends that clinical trials, I think I hopefully showed you, have a tremendous benefit to everybody. But specifically, a patient being involved in a clinical trial and a patient of color being involved in a clinical trial, that only helps them, but helps their family, helps their neighbors, helps their community being involved.
Thank you so much, Dr. Cole. I couldn't have said it any better. And I think that is the message. Let me just tell you guys that in the state of Michigan, all cancer clinical trials, in terms of just pure numbers of enrollment, we're at 4.4%. Right. Let that sink in, and then put in about another 10 or 20% at best of that 4.4% are persons of color. We have a long ways to go. So when you have a chance to participate, even if your provider doesn't ask you, you ask. Mm-hmm. That's you guys being your advocate for you, your family members, for your friends. Ask if there's an appropriate trial. Let the provider tell you whether there is one or there isn't one. So I know in the interest of time, I'm literally about to get the hook. I know we couldn't answer all of the questions on the chat, but I think if you have additional questions, you can email communityed@karmanos.org. We will try to get back to you by fielding it to the appropriate experts. We're going to take a 10-minute break. There are snacks and, of course, as we mentioned before, all-day coffee in the back and or other beverages. Please try to return back here. But if you can, the next 10 minutes after your bio break, please visit our vendors, again, community sponsors, as well as our pharma sponsors, to learn some more education. And then we're going to come right back here to have more education from our fabulous faculty. So see you back in 10.
She said, love don't come easy. It's a game of give and take. Can't really love. No, you just have to wait. You gotta trust, give it time. No matter how long it takes, but how many heartaches must I stand before I find the love to let me live again? Right now, the only thing that keeps me here.
It was the 3rd of September. That day I'll always remember. Yes, I will. 'Cause that was the day that my daddy died. I never got a chance to see him. Never heard nothing but bad things about him. Mama, I'm depending on you to tell me the truth. Mama just hung her head and said, son, Papa was a rolling stone. Wherever he laid his hat was his home. All he left us was alone. Oh, Papa was a rolling stone, my son, yeah. Wherever he laid his hat was his home. All he left us was alone. Hey, Mama, is it true what they say that Papa never worked a day in his life?
And Mama, some bad talk going around town saying that Papa had 3 outside children and another wife. And that ain't right.
Heard some talk about Papa doing some storefront preaching. Talked about saving souls and all the time leeching. Dealing in that and stealing in the name of the Lord. Mama just hung her head and said, Papa was a rolling stone, my son. Wherever he laid his hat was his home. And when he died, all he left was alone. Hey, Papa was a rolling stone. That coming wherever he laid his hat Say Papa never was much on thinking. Spent most of his time chasing women and drinking. Mama depended on you to tell me the truth.
Mama looked up with a tear in her eye and said, son,
Well, 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 well. Hey, yeah. All you left us was a long, 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 hey, yeah. All you left us was a long, I said, yes, he
very superstitious. Writings on the wall. Very superstitious. Letters about to fall. 13-month-old baby broke the looking glass. 7 years of bad luck. You put things in your past. When you believe in things that you don't understand, and you suffer. Superstition ain't the way. Yeah. Ooh, very superstitious. Wash your face and hands. Let me go the problem. Do all that you can. Keep me a daydream. Keep me going strong. You don't want to save me. Sad is the song. When you believe in things you don't understand, and you suffer. Superstition is the way. Yeah. Very superstitious.
You don't have to worry, 'cause baby, there ain't no mountain high enough, ain't no valley low enough, ain't no river wide enough to keep me from getting to you, baby.
Remember the day I set you free? I told you you could always count on me, darling. From that day on, I made a vow I'll be there when you want me some way, somehow.
Oh, baby, there ain't no mountain high enough, ain't no valley low enough, ain't no river wide enough to keep me from getting to you, baby.
Oh, no, darling.
No wind, no rain, or winter's cold can stop me, baby.
No, no, baby.
'Cause you are my goal.
I'll be there on the double. Just send for me,
Oh, baby, my love is alive, way down in my heart, although we are miles apart. If you ever need a helping hand, I'll be there on the double as fast as I can. And don't you know that there ain't no mountain high enough, ain't no valley low enough, ain't no river wide enough keep me from getting to you, babe. Don't you know that there ain't no mountain high enough, ain't no valley low enough, ain't no river wide enough, ain't no mountain high enough, ain't no You better think about what you're trying to do to me. Think let your mind go, let yourself be free. Let's go back, let's go way on, way back when. I didn't even know you couldn't have been too much more than 10. Just child. I ain't no psychiatrist, I ain't no doctor with degrees, but it don't take too much time to see what you're doing to me. You better think about what you're trying to do to me, yeah. Think, let your mind go, let yourself be free. Oh, freedom, 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 freedom. Yeah, freedom. Right now, freedom, freedom, freedom.
guys, if we can maybe get the folks outside to come in. Lots of good networking, lots of good snacking. I'm not sure, can our advocates and volunteers bring the crowd in so we can stay on track? Good? Oh, right. It's become synonymous with my face, I forgot. That's fabulous. Okay, well, I'm sure folks will meander in. I just want to mention that our next two speakers actually will have been pre-recorded. They have conflicts that pop up, and that's unfortunately happens in medicine, so patients first. We will hear from Dr. Sternberg, who is a terrific lung cancer physician, and he's going to update us on that. So unfortunately, because he's not live, we won't be able to answer any questions through the chat. But same thing, communityed@karmanos.org, or if you feel like you want to just write it on a piece of paper, we could give it to one of our advocates, and then we can get back to you on the actual answer. So that'll be very important. So, all right. Before we also get started, I'd like to thank the staff at Motor City for doing a terrific job, keeping us all fed and hydrated. And let's give them a round of applause. Thank you so much. You guys are terrific. I also want to thank the AVL group, which they're in the back, as well as in Lansing and Flint, making sure our audio, visual, and everything else goes off without a glitch. So let's give them a round of applause as well. And I would like to mention three really key individuals. One is Laura Zubek, Danielle Marshall, and Leslie Cortez for everything they've done to make this event work. They're right there in the back. They've done an outstanding job. It really does take a village, and we'll just keep going. So if AVL is ready, we can show the video from Dr. Sternberg.
Hi, everybody. My name is David Sternberg, and I'm an attending cardiothoracic surgeon at Karmanos Cancer Institute. And I'm sorry I couldn't be with you in person today, but I did unfortunately have a scheduling conflict. But I still wanted to record what I was asked to talk about so that I could at least share with you some of my experience as a lung cancer surgeon. One of the most important questions I'm asked when I meet people and tell them that I'm a lung cancer surgeon is, how can I beat lung cancer? What can I do to minimize my chance of getting and then ultimately succumbing to lung cancer? Now, while during this talk, which is going to be geared toward the non-medical professional, while I'm not going to be talking about specifics about lung cancer surgery, I would like to share with you the gestalt and what I talk to the patients and their families about overall when I'm meeting them or when I'm talking to patients who are just worried about the chances of getting lung cancer and ultimately succumbing to this terrible disease. Okay, my slide is not going forward. So first, lung cancer is the most common cause of cancer death on U.S. soil and also worldwide. Now, while lung cancer is not as common in prevalence as, say, breast cancer or pancreatic cancer, it is still the most important cause of cancer death. If someone is going to succumb, unfortunately, to a cancer, it is most likely that it will be a lung cancer. And if you look at the number of cancer deaths in the U.S. every year, there are about 130,000 deaths from lung cancer, which far eclipses the number of deaths caused by colon cancer, pancreas cancer, or female breast cancer. As a matter of fact, you could add the next several causes of cancer death together, and lung cancer would still eclipse them. So it is by far the most important cause of cancer death in the United States and elsewhere. But what can you do to minimize your chance of dying from this cancer? Today, I'm going to make concrete and actionable recommendations to minimize your chance of becoming a lung cancer mortality. But warning, none of my recommendations are any fun at all. Some of them decidedly less fun than others. So first, cigarette use and lung cancer. Now, I titled this slide, Coincidence? You Judge. But this is a publication that is put out by the CDC every single week. And what they actually report here is the relationship between consumption of tobacco or cigarettes in the United States, and they superimpose that with the death rate from lung cancer in the United States. And what you can clearly see is that starting in the early part of the 20th century, that cigarette consumption peaked at around 1960, and you can see the death from lung cancer following just about on schedule 20 to 20, 30 years later, which is exactly what our experience is, that from the time people start smoking, there's typically a lag period of 20 to 30 years before you start to see cancers actually showing up. So if anybody had any notion of the fact that lung cancer and cigarettes weren't intimately related, I hope this slide, if anything, dispels some of that confusion. So my number one recommendation to people who are concerned about lung cancer and lung cancer death is, of course, immediately stop smoking, period, amen. Because I think the previous slide told you everything you need to know about cigarette use and lung cancer. If you can't, lower your consumption as much as possible. The data on weaning cigarettes is incredibly depressing. I meet a lot of patients who tell me that they are cutting down. And while that sounds wonderful when they tell their family and friends that they're cutting down, the data on weaning cigarettes is really not very good. Weaning cigarettes is actually a less successful strategy than going cold turkey, which itself has a success rate of only 3%. So when I meet patients tell me that they are weaning themselves down, I often tell them that they are doing a disservice by continuing in that paradigm. But in reality, the only way to minimize in a meaningful way your lung cancer death rate is to stop smoking if you're smoking. The long-term data on vaping isn't in. The preliminary guess is that the health risk from vaping is not quite as bad as smoking cigarettes, but certainly not as good as not smoking at all. So while vaping may not be as bad as smoking 2 packs a day, nobody should confuse vaping with the equivalent of eating a salad. It is not health food. But let's shift gears for a second. What can you do to lower your chance from dying of lung cancer if you have already stopped smoking, but you used to smoke? There's excellent, compelling evidence that it is still possible to reduce your chance of getting a lung cancer and or dying of a lung cancer, and recommendations 2, 3, and 4, and actually a 5th will also address just that in just one moment. So the important thing to know about lung cancer is that an early diagnosis is everything. And if you look at this graphic from the Journal of Thoracic Oncology and you look at this data, what you can actually see are survival curves. And if you look on the bottom axis, what you actually see are how many years patients survive. And then the y-axis over on the left, you can see what the percentage of patients that are still alive are at certain time points. And as you move to the right of the curve, you can clearly see that stage 1E patients have the best survival. They tend to die as least often, but unfortunately, the stage 3 and stage 4 patients have much worse survival. So the point I'm trying to make by putting this slide up there is not to scare everyone who unfortunately may have had a higher stage diagnosis in their past, but to tell you that, as one would imagine, the higher the stage, the lower the chance of surviving, which is to tell us that what you would like to do is be caught as a stage 1 or a stage 2. And that if you have your druthers and if you have smoked, the most important thing you can do to prevent the lung cancer death is to try to catch a lung cancer if you are unfortunate enough to get one at an early stage where the chance of successful cure is much, much higher. Now, this data is followed by this additional data that was put out by Margaret Leuchtenberg in 2014. And what this data shows is that when a cancer is removed, survival of the patients is significantly better. So if you actually look at the solid lines, you look at both non-small cell and small cell lung cancer, you can see that survival for small cell and non-small cell is significantly higher. And what this slide says is it almost doesn't matter what the biology of the lung cancer is. If it can be removed, your chances of surviving the cancer is much higher, which builds on what I was mentioning in the previous slide, that the most important thing to reduce your lung cancer death rate is to not smoke or stop smoking. But if you have smoked and you are at a risk of getting cancer, the next most important thing you can do is to try to be diagnosed early in the disease process as a stage 1 or a stage 2 when your cancer can be removed. Because if you catch that cancer early and it can be removed, you can expect that your survival will be much higher than if your cancer is caught at a higher stage where it is no longer something that can be removed surgically. This is additional data that was published only 3 years later and confirms the data that was seen on the previous slide, that again, if you can get the cancer out, you have significantly improved the patient's chance of surviving. And if you can't get the cancer out, you can expect their survival to be significantly worse, even within a few years. So enter lung cancer screening. In 2010, the United States Preventative Task Force released data from a very large study, the National Lung Cancer Screening Trial, that showed that screening for lung cancer with a low-dose CT scan could catch lung cancer at an earlier, more curable stage, thus improving survival. And this is data that was actually released from the NLST research team, and what you can actually see is the red arm, which was a chest X-ray arm, experiences significantly more cases, cancer caught with a CAT scan than with a chest X-ray. And so the point that this slide is trying to make is that you are significantly more likely to catch lung cancers by screening them with a CAT scan. And building to what I mentioned earlier, if you can catch these cancers at an earlier stage, your chances of removing them are higher and your chances of surviving them are also higher. Which leads me to recommendation 2. If you meet criteria, get screened for lung cancer. And what are these criteria? If you are 50 to 80 years old, or you have smoked 20 pack years in total, or are smoking currently or quit within the last 15 years, the next most important thing you can do after stopping smoking cigarettes is to get screened for lung cancer, to try and catch the cancer as quickly as possible or at as early stage as possible. Recommendation 3, if it's at all possible, have your cancer resected. And as I showed you, survival for cancer that is treated with resection is significantly better. And what you see in data that was presented in 2018 is that patients who were treated with trimodality therapy, which is to say, patients, these are only stage 3 non-small cell cancer patients, but if they were treated with chemotherapy, radiation therapy, and then their cancer is removed, their survival is significantly better than patients who received just chemotherapy or radiation therapy, or even a combination of chemotherapy and radiation therapy. But the act of removing the cancer is significantly likely to improve your survival if you catch or if you get a lung cancer. And then finally, recommendation 4, and this is where it gets even less fun. Try to become the kind of person that makes it much harder for genetic mutations to happen in your body. And what do I mean by that? You want to be someone whose body is not a factory for creating genetic mutations. Cancer is caused by the creation of genetic mutations. And when patients respond to chemotherapy, that response is often not durable, meaning the chemotherapy works for a period of time, but then unfortunately it doesn't respond anymore, and mutations are created or have been created in the cancer, which is typically genetically unstable, and that allows the cancer to progress despite the administration of the chemotherapy, which often means that the chemo won't work anymore and that the patients will progress and get worse. So one of the things that you can do, assuming that you either can't get the cancer out or you've even gotten the cancer out, is to try to make it difficult for genetic mutations to happen. Be the kind of person whose body is not conducive toward the creation of cancer-causing mutations. And what does that actually mean? How does one go ahead and do that? Well, for one thing, clean up your nutrition. Meat cooked at very high temperatures contains polycyclic aromatic hydrocarbons and heterocyclic amines. These are cancer causing, and the safe dose of red meat per day is less than 1 hamburger patty. So if you are eating high doses of red meat, like the average American, having several large servings of red meat or meat per day, you should consider cleaning it up. You should consider significantly reducing the amount of red meat you eat specifically and meat in general. Meat processed with nitrates, specifically foods like hot dogs and pepperoni and hams and bolognas and salamis. These meats are processed with nitrates that also contain nitroso compounds, which are also cancer-causing. And there's not just good evidence that they cause bowel cancer, but they also increase other forms of cancer as well. But even starchy foods, when cooked at very high temperature, especially frying, contain high levels of acrylamide, which when we worked with in the laboratory, we treated as an absolute carcinogen. We used barrier precautions before touching acrylamide in a research laboratory, but you can create and form acrylamides in your food by taking something like potatoes and frying it. So consider not eating starchy foods, especially when they are fried at incredibly high temperatures, such as boiling them in vegetable oils. And then alcohol is also metabolized to acetaldehyde, which is a direct carcinogen. And then finally, concentrated and refined carbohydrates also promote both an inflammatory and oxidatively stressful environment in your body. So I know what you're thinking. Come on, surely I'm joking. What are we supposed to eat? But the data is really quite good that the increasing your intake of red meat increases your risk of cancer, and you can see a hazards ratio. Initially, the preliminary idea was that high doses of red meat would increase your risk of cancer by 20%. The reality is it may be an additional 12 to 20%, maybe not as high as 20%, but it is certainly true that large intake of red meat per day increases your risk of carcinogenesis. Same thing with nitrite intake, which I display in the screen on the right. And at the bottom, you can clearly see that your adjusted risk for cancer with mild, moderate, or heavy alcohol use actually increases. So if you are someone who is looking to specifically avoid a cancer diagnosis, especially in the lungs, or you have had a lung cancer diagnosis and you are looking not to have a recurrence or to minimize the genetic aggressiveness of a recurrence, strongly suggest you avoid these foods. And one other less discussed recommendation on how to decrease the risk of mutation in your body is to check the radon levels, which is recommendation 5. Radon is the #1 cause of lung cancer in non-smokers. It's also the second leading cause of lung cancer death and is responsible for 13% of all lung cancer deaths. It synergizes in cigarette smokers. So people who smoke cigarettes and also have radon gas, and radon, by the way, is an invisible and radioactive gas that is released by the Earth's crust. It synergizes. Cigarette smokers have a much higher increase in lung cancer when they not only smoke cigarettes, but they also have higher concentrations of radon gas in their basement or their homes. So if you haven't checked the radon levels in your basement or in your home, you should certainly check it. This is not an expensive recommendation. I was able to pull this off of my Amazon inbox, and you can clearly see that a radon gas test kit costs $15.98 on Amazon. And you can compare how much just a single consultation with an oncologist, let alone admission, chemotherapy, radiation therapy, surgery, surveillance imaging. If you compare the cost effectiveness of checking for radon versus cancer care, it is an astounding difference. Everybody should check their basements for radon gas. Most of the time when patients who never smoked and were never exposed to lung cancer and have the family history develop lung cancer, we often tend to think of them as possibly having high radon levels in their basement, and that often does pan out as a clinical suspicion. So thank you. And finally, for those of you that are experiencing a lung cancer or dealing with a lung cancer, I put a picture of a graphic of my absolute favorite frog choking his opponent even when things look grim. And that is, of course, the kind of attitude we have. And you must have in order to successfully beat lung cancer, but lung cancer is a beatable foe. It should be noted that before 100 years ago, lung cancer was almost unknown in human disease. It was not a significant cause of death, let alone cancer death, in Americans or Europeans prior to the beginning of the 20th century. It's a disease that traditionally did not happen in humans up until a little more than 100